Paramedicine in Australia is slowly moving from a pre-hospital trade to a healthcare profession. Throughout this transition, new opportunities will arise for current and future paramedics. Previously unthought of technologies will be put into common practice, and the service's key role will drift according to society's changing expectations. The current paramilitary rank structure and progression system within the Queensland Ambulance Service is incredibly rigid. As the scope of practice of advanced care paramedics slowly broadens, we will see a gradual shift to paramedic practitioners on road. The traditional roles will be broadened and new roles will open. This presentation will examine the shift from the perspective of a third-year student currently undertaking their final exams. It will also examine the changes that I have observed in even the short 3 years that I've experienced on-road learning. Finally, we will look at the changes that I see coming in the near future. The way that universities teach paramedicine is almost completely focused on the acute presentation of life-threatening conditions. Unfortunately, society's expectation for the ambulance service is very different to this. In the past 18 weeks on road, I have been to just shy of 400 patients. In total, only 22 of these have been what I would consider as a high acuity case, which include major trauma, cardiac arrest, and other immediately life-threatening conditions. This means that up to 95% of cases are not specifically targeted at university. While we do a mental health subject, along with the communication subject, very little of our teaching is aimed at the reality of the low acuity work within the service. Universities as a whole do not prepare students for the reality of paramedic practice. While some universities are adopting a 4-year degree, with more focus put towards community paramedicine, the vast majority are caught in between teaching the bare minimum to scrape by in low acuity cases while still allowing students to manage high acuity cases efficiently. As mentioned, I have recently come to grips with the lack of preparedness that students leave university with. I believe that as the current university system gives us the bare minimum possible for us to be successful on road. We are not taught for the reality of community paramedicine, which is how the profession is leading towards. We are taught the basic theories of communication, but not how to deal with the vast majority of low acuity cases. Community paramedicine is a recently coined term explaining the adaptation of paramedics into the management of low acuity illness and injury. Using paramedics in low acuity cases has been shown to be beneficial to both patient outcomes as well as the healthcare system as a whole. By reducing emergency department visits for low acuity cases, community paramedicine can help reduce overall loads on hospital. This allows the high acuity cases to be seen faster by doctors, saving both time and money, along with improving patient outcomes. The Low Acuity Response Unit Program, or LARU, in Queensland is taking a step in the right direction, providing paramedics with advanced training in how to deal with low acuity cases. The primary reason for these crews' existence is to avoid taking certain patients to hospital. These crews, unfortunately, are few and far between, and unfortunately the way that the phone calls from patients are taken, not enough cases are filtered down to these LARU crews. I have personally seen the start of telemedicine used regularly on road, with ACP2 crews now being able to consult for a variety of skills. This allows crews to essentially upskill without having to increase their overall responsibility of the decision. I have seen these skills both used in mental health cases along with cardiac cases. Telemedicine is just that. It is seen as a way to shift blame and shift responsibilities off the paramedics on road. In the coming year, this skill will be developed with more and more use on road and expanded methods of use. I believe that the future roles of paramedics will change in two major ways. The regular and efficient use of community paramedicine will shift the practice down the low acuity route. At the same time, the incorporation of future technologies into current practice will change our roles completely. With higher education now mandatory for Australian paramedics, we now have both the ability and advanced knowledge to apply these skills in a variety of ways. By recognizing these skills, the profession can grow rapidly, allowing for both career progression and supporting workplace retention. As mentioned, community paramedicine is a new and evolving field that paramedics are being pushed towards by societal expectation. Paramedics have a unique vantage point and have access into patients' homes, something primarily unseen in other health professions. This leads to increased levels of trust, which means that we as paramedics can be easily adapted to treat low acuity cases. While this has previously been delegated into community nursing, paramedics have further diagnosis skills with very little adaptation to the profession. Low acuity cases like these have been previously seen as a misuse of service. The advantage to treating people in their own homes cannot be understated, with increased patient compliance and patient outcomes often resulting from home-based care. It has also been suggested that we, as paramedics, should and can be leaders within our community. We should be the ones who train what to call for and where the boundaries of other services lie. Unfortunately, this has been met with vast hostility on road, with the vast majority of paramedics thinking that higher levels of engagement lead to higher number of calls. This has been related to breaking the ice. The uncomfortableness of the first contact with any service causes hesitation to make contact. Once comfortable, patients tend to call more often. This has been seen by many of my mentors on road and is a major barrier that we as a service have to overcome. Once again, LaRue is a step in the right direction. The medical director of the QAS, Steve Rashford, has recently stated to QUT students that we will always need stretcher ambulances. However, the way that the society is pushing the profession, we will have more and more cars on the road in the coming years. In the United Kingdom, paramedics are being upskilled right now into paramedic practitioners. They are able to diagnose, treat, and discharge with the backing of the service behind them. In the upcoming years, Australia will expand its low acuity care program, with paramedic practitioners being put in place alongside and in replacement of LaRue teams. As we expand into the realm of general health professionals, we will have more opportunity to use previously unthought of technologies. These include telemedicine, as mentioned, cognitive computing and artificial intelligence, as well as both robotics and automation. Telemedicine is already in use within Queensland healthcare. However, we will soon be able to enhance the ability of this technology. Paramedics will soon be able to communicate directly with patients on scene, as well as with doctors straight at the hospital. Hospital physicians may soon be able to help diagnose with paramedics both over the phone and by collaborating using advanced technologies such as the Oculus Rift and HD vision glasses. This would allow for diagnosis, treatment, and essentially discharge, all without leaving the patient's home. The increase in paramedic autonomy from this technology would come without the risk of backlash from leaving patients at home, as the current service is one of fear of potential repercussions. This technology could simply act as an addition to either ACP or LaRue crews, assisting them to find set diagnosis and treatment pathways for every patient. Telemedicine also have massive applications in the Australian outback. Due to the large distances and massive size of the outback, many patients have extensive wait times for ACP crews or transport to definitive care. By incorporating telemedicine into our practice, a first responder in a rural area could potentially allow doctors to provide the patient with a full diagnosis and treatment plan without having to travel to the closest emergency department. In the recent years, we have seen a massive spike in cognitive computing and artificial intelligence. This technology will soon take over from our current communications officers. Artificial intelligence will be able to not only answer phone calls, but filter cases, allocate crews to jobs, and give timely, appropriate information to crews. By allowing cognitive computing to overtake these tasks, paramedic fleets and resources will be optimized across the state, allowing previously unheard of efficiency. By taking phone calls with artificial intelligence, it will be able to ask more questions and filter cases to more appropriate crews, both high and low acuity. It will also be able to spend more time on the phone and give the same information across to those placing the calls, as a computer is not limited to a single phone call at a time, like a human is. Robotics and automation could also potentially revolutionize the workforce. Self-driving vehicles are already in place in military applications and for taxis, and could potentially allow for single responding paramedics to give full patient care while the vehicle drives itself. This would allow more clinical time with patients, and for high acuity cases, 2 crews could simply be dispatched, with the second truck driving itself back to hospital while the 2 paramedics treated the patient. Change within a profession will always take time. Paramedicine is not an exception to this rule, with people's lives literally at stake if we make a rash decision or poor change within the service. As a result, all changes must be what we as a service, individual, and society want. Any changes must benefit society as a whole, if not only on a minor level. The adaptation of military technologies into civilian application has and will always be met with hesitation, with the medical field being full of examples. Overall, all changes will be governed and limited by the individual state service. Risk-benefit analysis will be conducted based on the service's perceived needs and the direction that the service decides to take. I believe that within the next 5 years, the paramedic profession will adapt into community paramedicine, with less and less stretcher crews. However, there will always be a need for stretcher ambulances, and this is where advanced technology can help reduce load and increase overall patient outcomes. Telemedicine is the other avenue that I believe will be rapidly adopted into the service, with the potential benefits being enormous for a fractional relative cost. As a student, the idea of expanding roles within the service and the idea of further progression pathways is exciting. By opening up further avenues for paramedics, not only do patient outcomes improve, but staff well-being and staff retention also improve. For students on the road, the idea of being able to incorporate modern technology is exciting. Whether the changes will happen in the coming days, months, or years, I cannot say. In the end, only time will tell.